Hello everybody and welcome back. Today our topic is going to be about the ECG or the electrocardiogram. The ECG is the standard clinical tool used to measure the electrical activity of the heart. The ECG is used commonly because it's non-invasive, inexpensive and versatile. The ECG is used for detecting arrhythmias, conduction disturbances, myocardial ischemia, cardiac enlargement and hypertrophy, metabolic disturbances, and increased susceptibility to sudden death like the QT prolongation syndromes. The electrocardiogram or ECG is a graphic recording of electrical potentials generated by the heart. The heart is suspended in a conductive medium. The signals are detected by means of metal electrodes attached to the skin, amplified and recorded by the electrocardiograph. The depolarization and repolarization waves. The depolarization, moving toward positive electrode, generates a positive wave. So it's from negative to positive, it generates a positive wave. The repolarization, which is from positive to negative, generates a negative wave. No potential difference, homogeneous charge, only positive or only negative, generates an isoelectric line. So if it's not positive, not negative, it's an isoelectric line. Characteristics of the normal ECG. The normal ECG consists of a number of waves, positive and negative waves, connected through segments of isoelectric lines. The waves correspond to depolarization and repolarization of the heart surface during the cardiac cycle. Now we're going to talk about the waves. The first wave is the P wave. The P wave is the atrial depolarization. The second wave is the QRS complex. It is the ventricular activation. And the last wave, which is the T wave, is the ventricular recovery. There is also a PQ segment, which is the delayed conduction in the atrioventricular node. So it takes time for the conduction to reach from the atrium to the ventricles. This delayed conduction is the PQ segment. Relationship between a ventricular action potential and QRS, which is the T waves on the ECG. It's a monophasic action potential from a ventricular muscle fiber, which is recorded on the ECG simultaneously. It appears, the QRS appears at the beginning of the action potential and the T wave at the end. So in the beginning of an action potential, it starts with the QRS complex and it ends with the end of the T wave. No potential is recorded in the electrocardiogram when the ventricular muscle is either completely polarized or completely depolarized. The rapid upstroke, which is phase 0 of the action potential, corresponds to the onset of the QRS. Factors that decrease the slope of phase 0 by impairing the influx of sodium, like hyperkalemia, tend to increase the QRS duration. The plateau phase, which is phase 2, corresponds to the isoelectric ST segment. Conditions that prolong phase 2 are hypocalcemia, which also cause the increase of the ST segment. Shortening of phase 2, like digitalis or hypercalcemia, abbreviates and shortens the ST segment. The active repolarization, which is phase 3, corresponds to the T wave. The electrical currents that spread through the heart are produced by pacemaker cells, specialized conduction system, and the heart muscle itself. The ECG records only the extracellular currents generated by the atrial and ventricular myocardium. The cardiac depolarization and repolarization waves have direction and magnitude. They can be represented by vectors. The ECG records the spatial and temporal summation of electrical potentials, which are the vectors from multiple myocardial fibers conducted to the surface of the body. Inherent limitations in sensitivity and in specificity. So in sensitivity is the activity of certain region may be cancelled out or may be too weak or to be recorded. So it can be very weak to be recorded or cancelled out. In specificity, the same vectoral sum can result from either a selective gain or a loss of forces in opposite directions. So this was everything for today. Thank you very much and hope to see you soon again in the next video.